Hello, welcome to this 19th episode of EBMT podcast Blood Matters, a podcast for nurses. My name is Hilda Mekelenkamp and I'm together today with Kenyon.
Hi,
Welcome,
Hilda.
Michelle. How are you
Hi.
doing?
I'm good, thanks. How are you?
I'm good, thank you. We have a very exciting topic today, right?
We do, indeed, indeed. And something I'm particularly interested in, but something that you've got a topic you've got quite a lot of experience in.
Yeah, it's really true. The topic of today is hemoglobinopathy and the transplant for hemoglobinopathies. And with that, we mean mainly the sickle cell disease and transfusion-dependent thalassemia. And it is really an indication for HSCT, which we have seen growing over the past years. How's that for you?
Yeah, indeed. Yeah, we started our adult program just in the year prior to the pandemic. Prior to that, we had done an odd couple of patients for sickle cell. And yeah, it's growing, and there's a lot of demand. Yeah, and it's very
Yeah.
interesting group of people to work with. Very privileged and delighted to have the opportunity to work with people with non-malignant hematological disease.
Yeah, it's a non-malignant disease, but it is really also a disease, affecting the quality of life of these patients, but also, yeah, lowering their life expectancy.
Yeah,
And we have two wonderful guests today who
yeah.
will join us. It is first Sandrine Bremathas. She is a pediatric bone marrow transplant coordinator at St. Mary's Hospital in London. She worked for a couple of years in pediatric hematology, and she worked mainly with patients with non-malignant BMTs for the last years. She's part of the apheresis team, and she has a special interest for patients with red cell disorders. And she's the nurse representative for the hemoglobinopathies working party of EBMT, and also the pediatric representatives for the UK National EBMT group. So that's great. And our second guest is Dr. Donatella Baronciani. She is a medical doctor with a specialization in hematology and pediatrics, so involved in adults and pediatrics, both in malignant and non-malignant diseases. And she has a lot of experience with thalassemia patients. She worked in Pesaro and Cagliari, Italy, but now she's retired from clinical care, but she's still quite involved in the hemoglobinopathy working party and as a JC inspector. So I think we can welcome them both on the podcast right now.
Yeah, be great. Thank you. So we're now joined by both of our guests. Hello to everybody. And I'm just going to run in with the first question. So what do you see, Donatella, as the most significant advancements that you've seen in curative therapies for patients with hemoglobinopathy in recent years?
Yes, if we speak about transplant, allogeneic transplantation, I would say that the big advancement in this field is the diffusion that this procedure had in these years. In fact, now it is performed worldwide with excellent result if we consider that thalassemia patients can have an overall survival of more than 90% if this procedure is performed when they are children and from an HLA identical donor. So for transplant, I would say the diffusion of this procedure. For gene therapy, I would say that after many years of alternating experience and results, finally, in the recent year, we had the clinical trials that gave very good results both in thalassemia and sickle cell disease, even if some problems have to be resolved because the gene therapy products are not so available and are very expensive.
That's absolutely right. Yeah, thank you very much, Donatella. I'm going to hand over to Hilda now.
Thank you. Donatella, how do you approach the decision-making process for HSCT, but also for gene therapy in individual patients with a hemoglobinopathy, as it is not a one-direction decision?
For the decision analysis, I think that for thalassemia, the absolute indication to the allotransplantation, but also to the gene therapy, is the transfusion dependency. So if patients need regular transfusion and of course also chelation treatment to live, this is an absolute indication to this procedure. And the best results, as I mentioned, has to be are reached when patients are young and if they have an HLA identical donor. For gene therapy, is the same indication, and for sickle cell disease, that is a completely different disease. The indication is when patients have a severe form of the disease. If in this case, age is an important risk factor, and to have an HLA identical donor too, because at the moment, alternative donor transplant don't give so good results.
Thank you so much, Donatella. I hand over to Michelle for the next question.
Yeah, thanks very much, Donatella. Sandrine, I just had a sort of question to run on from that, really. What's it like for you as the clinical nurse specialist when, you know, there are treatments available for patients? Do you get contacted often by patients who think they might be eligible for a certain treatment, and how do you navigate that as a nurse?
Thanks, Michelle. So yes, we do get contacted by our family. So a lot of our children come in for regular treatments. So say patients with sickle cell disease will come in for their regular blood transfusions, automated red cell exchanges, and patients with transfusion-dependent thalassemia will come in again for their monthly transfusions. Often, it's quite a small community where all the parents and families will know each other and will discuss between them the different treatments available. They will then, of course, approach us as clinical nurse specialists or other members of the team as well to see if they could discuss the treatments available further. And then the appropriate referral would be done in clinic, and then they would meet the relevant consultant and discuss the treatments available.
Okay. Do you ever approached by patients who you know wouldn't be eligible for certain treatments, and is that very difficult?
Yes, it can be challenging because some of them really just want a long-term cure, and they just want a better quality of life. So yes, they will approach us. We will then give us the whole picture of what it entails to have a transplant. And we would go through all the risks, the benefits, and detail, every complication that it can be, and then make them understand as to, whether the decision of a BMT is good or bad. And it can be challenging, very disappointing for the families as well sometimes, because they're so desperate for a curative treatment. Yeah. But at times it's just not the right one for that particular patient and family.
Thanks very much, Sandrine. That's really lovely context. Donatella, we know that, I guess, most of the stem cell transplants for hemoglobinopathies are performed in the high resource countries, but at the same time, most of the people affected live in low resource settings. How can we bridge this gap in access to treatment?
Yes, Michelle, this is true, but now things are changing, have changed and are changing rapidly, because also in low-income countries now there are centers that perform transplant. And in fact, this is demonstrated also from the EBMT hemoglobinopathy registry, because there are more and more transplant reported from centers in Asia and also in Africa. And also inside the hemoglobinopathy working party, there is a program for these countries that try to help and to increase the knowledges and the skills in this country to perform transplant. For what concerns gene therapy, I would say that we have to wait, because the gene therapy products are a pharmaceutical problem, so they are expensive, and I don't think that in this moment this could be feasible in this country. Also, because we know that also in the industrialized country, the cost of gene therapy is a problem, and there is a big discussion between the industry and the regulatory agency for this hot topic.
Thank you so much. Lots to think about there, Donatella. Over to you, Hilda.
Thank you so much, Michelle. And I also had a question based on your answer just about the gene therapy for the low-income countries, Donatella. What do you expect for the future? In what time frame can we expect gene therapies also in low-income countries?
For the future, for most of all for the transplant, I would expect that we can find always new conditioning regimen that can be always effective but less toxic for this patient in terms of the short toxicity, but also for long toxicities like also the fertility preservation. And then I would expect for the transplant to expand the donors, to have better result with alternative donors, and to have the possibility to do transplant also for adult patients that are excluded for the not so good results. For gene therapy, I would expect to have gene therapy product less expensive and with a large availability for these patients.
Yeah, thank you so much. And what are your thoughts on the current patient selection process for HSCT? And does it really reflect true equity, or are there implicit biases that affect who get access to HSCT or gene therapy?
For transplant in the Western European countries, I don't think that there are a big bias for the selection of the patients. Sometimes patients can do the transplant, but for medical reason, because they have organ damages and so on. In the incoming countries, maybe the transplant cannot be done because the financial, economic resources are very low, and also the economic situation of the families. But we know that some families that have a financial possibility move from their country and go to other countries where the procedure is available. And I want to stress the fact that in not industrialized countries, also the conventional treatment of this patient is very expensive, because if we think that regular transfusion, chelation treatment is expensive for thalassemia patient, and a transplant is cost effective, if we consider that one transplant procedure is more or less equivalent to 3-5 years of conventional treatment in thalassemia patient. So this is this problem.
Thank you so much, Donatella. I think that's really true. And I think the cost effectiveness is really important to also highlight for this group of patients. Thank you so much.
Yes.
We hand over now to Michelle to start with the first question for Sandrine. Thank you so much, Donatella, for so far. But we come back to you later.
Okay, thank you.
Thank you very much, Donatella. So Sandrine, so in your role as a nurse working with these patients, how do you see this evolving, particularly for patients who are considering undergoing a transplant?
So I think the nurse plays a very important role in preparing and supporting these children and their families. I would say with my particular role, I would say that I have a few hats on, essentially, where we're supporting the families and the patients right from the beginning when we first meet them in clinic, throughout the entire journey until the end of it. And we often are big advocates to our families, to our children. We look at them from a psychosocial perspective, and we help them financially, we help them with as a holistic care, essentially. And I think we play a big part looking after our patients. I know that the Royal College of Nursing last year as well published a competency framework for staff looking after children and patients with sickle cell disease and thalassemia. And again, that competency in the framework actually highlights a lot of the elements that we should implement on a day-to-day basis. So I think nurses do play a big part in the journey of these patients.
Thank you very much, Sandrine. I absolutely agree. Hilda, over to you.
Thank you so much. We already spoke a little bit about it, Sandrine, but discussing and offering an HSCT for patients with hemoglobinopathy and especially sickle cell disease, I think, is not so straightforward. It often depends on the beliefs, but also the knowledge and experience of healthcare professionals. What is your perspective on this, and what is needed to ensure more equitable and informed decision making for all these patients?
Sure. So like Donatella was saying earlier, I think there is no, I find this, especially in our place of practice, there is no bias as such. Each family and patient is counselled, like anybody else, despite of where they come from, their religious background. We of course adapt to each family individually. We will use, translators when need be. We are aware of their cultural beliefs, their religions, and it can be challenging to navigate through. Though with the help of the entire multidisciplinary team, we're able, I find, to provide the right relevant care to them.
Thank you so much. And do you think that all referring centers do refer the same patients as you are speaking to yourselves as a stem cell transplant center? Sometimes referring centers do not have that same experience, and sometimes we see a difference in that indications for referral. How do you see that?
That's right. Often when we see patients for the first time, they'll present to the BMT clinic. And once we give them an overview of the entire treatment, a lot of the information they're actually not aware of. For example, complications such as infertility risk. That's often a big shock to the families of the patients that are coming because, again, not all referring centers are aware of, all the risks and all the benefits of the treatment. So we, as a transplant center and in clinic, we, openly tell them all the goods and bads about the BMT process, the treatment, and we try and give them as much information as possible so that they're able to make that decision with all the information available.
Thanks so much. I hand over to Michelle for the next question.
Thanks so much. So Sandrine, my question is really linked to that because the decision-making process for having a transplant is really hard, whether you have sickle cell disease or whether you have leukemia. But are there any specific tools that you use to support patients and their families with making a transplant decision for hemoglobinopathy?
So when we do meet with them in clinic, they will meet, the lead consultant numerous amount of times. They will meet us as BMT coordinators. The families will meet with our psychologist, the play team, our dietitian, and there's a wide range of different professionals that they meet at numerous times. And then once the decision, once they have all the information available, they're actually happy with that decision, then we will then invite them to sign the consent. So they do have a lot of input, I would say, and a lot of counselling prior to actually making that decision.
Great. Thanks, Sandrine. And any particular tools that you use? Any information, multimedia, podcasts, any resources that you use in addition to the multidisciplinary team to help support the decision making and support informed decision making?
Yeah. So we do use the 7 steps, the Antonin 7 steps book, which highlights a lot of the process. And we do use other books.
I know it.
Yeah. Yeah, we do use a lot of other books as well, and a lot of literature and papers as well. Yeah.
Thanks so much, Sandrine. Is there anything that's specifically tailored towards the information needs for hemoglobinopathy patients?
Yes, we do have information leaflets, yes, within the trust that we use. So those will be sort of literature that we do give to our families.
Brilliant. Thanks very much, Sandrine. Thank you. Back over to you, Hilda.
Sometimes there's a difference made between the non-malignant and the malignant patients. Do you see, Sandrine, any difference between the acute versus non-acute indications, like, for example, leukemia and sickle cell disease? Do you see any differences and how that affect the support you give?
Sure. So with my particular role, I guess, so in my area of expertise, I do non-malignant transplants. And therefore it's quite hard for me to comment on the malignant, transplants. But from a hemoglobinopathies point of view, our families, when we do work them up, the process takes around 3 to 6 months, sometimes longer, so that they have all the information available. Like I said earlier, we look at, the psychosocial aspect of things as well. Do they have an adequate house that's mold-free and damp-free? Do they have, transport that's available? Do they have the right support? And sometimes actually ensuring that they have all these things in place can take a good couple of months. So I suppose it's difficult for me to compare it to the malignant setting because I know it's a lot quicker. Whereas with us, it is an elective procedure, and therefore we want them to be fully prepared when they actually enter the journey, because once we've entered, there is no going back. So we want to ensure that they have all the relevant support and then embark on that journey.
Thank you so much. I think it's now time for our next round, which is a quick fire round. Can I hand over to you, Michelle, for this?
Of course,
round?
Thank you so much. I'm going to ask my first question to yourself, Donatella. So in your opinion, where should future research efforts be focused regarding transplantation for patients with hemoglobinopathy?
As I mentioned before, for the transplant, I would expect to improve the preparation to the transplant, so the conditioning, because this is a big gap for patients, because the conditions are usually myeloablative for this kind of patient, for the expansion of the bone marrow. So we need a myeloablative condition, but on the other hand, we need to give the less toxicity what we can. So better conditioning, expanding the donors for the patients, and also expand the transplant to the adult patients that now are excluded. This is for the allogeneic transplant.
Thanks so much, Donatella. And to yourself, Sandrine, the same question.
Sure. I was also going to mention about a more non-myeloablative approach. I know that last year there was a paper released in 2024, so last year, where we looked at doing non-myeloablative conditioning for patients with sickle cell disease above the age of 16. We know that patients with sickle cell disease have got a lot more comorbidities and a lot more organ damage. So the use of chemotherapy can be highly toxic. And this particular paper, for example, looked at azathioprine and hydroxycarbamide as preconditioning, and then with the use of alemtuzumab and TBI. Again, you can see that what is used is not as myeloablative as the chemo. And I think future research should be focused on that sort of approach, so that all patients can still have an opportunity to have treatment, but not with such toxic drugs.
Yeah, and we're gathering that experience in the adult setting with the non-myeloablative protocols. So there's certainly lots that the communities can learn from each other, isn't there, around the conditioning. Over to you, Hilda, for the next question.
Thank you so much. Donatella, what advice would you give to patients with a hemoglobinopathy and their families who are considering HSCT or gene therapy?
When in a family there is a patient with an hemoglobinopathy, the first advice that I would give them is to go to research an expert hemoglobinopathy and transplant center to make a consultant, and so they can understand which are the approach that there are in the world in this moment for these diseases. Then the patient and family can decide what they want to do. And this is very important, because we know that to go to expert center make the difference. In Italy, we had a paper that demonstrated that the patients, thalassemia patients, followed by in an expert center have better survival than the patients that don't have this fortune, this luck. And also the message that I would like to give, that in the meantime, that patients is wait for the transplant, transplant or for the gene therapy, they have to be well treated, so well transfused, well chelated, because the clinical condition of the patients are important for the transplant and also for the gene therapy. So the message is try to keep this patient at the best that we can.
Yeah, thanks so much. So the best knowledge and experience is needed, but also the best preparations. I fully agree with that. Sandrine, how would you answer this question?
I would say that it's important for them to have a good understanding of the whole treatment, from start to finish. The families need to understand the length and the intensity of the treatment. They need to accept the transplant-related mortality. And again, when we quote, for example, 2 to 5% as a death risk, it may not mean much in terms of a figure, but actually it is 1 in 20. And we do highlight the importance of that actually for the families to accept that. And it's also important to understand the long-term complications, the infertility risk, and every other complications that is associated with BMT. So I think my advice would be that the patients really need to have a very, very good understanding and actually not to rush the process, especially as it is an elective treatment in a lot of our children.
Thank you so much, Sandrine. It's really important indeed to highlight that the understanding of the patients needs to be really fixed, because we see a lot of misunderstandings and managing expectations in hindsight in these patients groups. What is your experience with that?
Yes, sometimes there is a misconception, for example, that the treatment will be done without the use of chemotherapy, or they don't really realize the intensity of the treatment. The initial stay of, for example, 6 to 8 weeks as an inpatient, sometimes longer. And then the post-transplant care, where they would come to the hospital 2, 3 times a week, be monitored so closely. And I think that families don't realize the intensity of the treatment until it's sort of really spelled out to them, and actually it can be very challenging. So I think that we just reassure them, we give them a lot of information, we sort of go through things as the treatment progresses. So I think it's important for them to just know all the details.
Yeah, thanks so much.
I can add something. For this reason, it's important that patients have a good consultation in an expertise center, because they have time to reflect, they have time to think. There is not a malignant disease. So while in the malignant disease, patients and parents are very stressed because they are the life. In these cases, this is the life of the patient, but parents and patient can have to understand and have to think what they're going to do. So there is time to reflect, and so they need a very good consultation.
Thanks so much. So time is not so precious in this case, but really precious to use it, to give all those information. Thanks a lot. Thanks a lot, both of you. We are coming to an end of this podcast, and we really appreciate your valuable input. Thank you so much.
Thanks to you for the invitation.
Yeah, thank you so much to you both. We really learnt a lot, and it was really great to have the benefit of your insights and your experiences. For sure, the field of transplantation and cell therapy, gene therapy is growing in hemoglobinopathies. And while we haven't reached a point yet, I don't think, where we have mastered all of the things that we need to, for sure, we're on a really exciting journey that is going to benefit these patients in the longer term, and really make such a difference to the community more generally. So a huge thank you to you both for joining us on the podcast this morning. I'd also like to thank yourself, Hilda, for joining me as a co-host. I also want to thank the background team, and most importantly, to thank the listeners for joining us, and look out for further details of the next episode. Thank you very much, everybody.
You to you.